Every week, Surfing the MASH Tsunami brings you three major stories from the world of steatotic liver disease. This weekend, we're bringing you each of these stories separately so you can listen over a shorter, discrete period of time. Hope you enjoy them.
For the last 5 years, MASLD stakeholders, whether manufacturers, trial sites, providers, payers, patients, or investors, have turned to Surfing the MASH Tsunami to keep track of drug and device development, epidemiology, public health initiatives, and practice patterns. This weekend, we are sharing the three main sections from our episode 7. Roger will provide more information after these notes from our sponsors.
Surfing the MASH Tsunami is sponsored by these healthcare-related organizations.
Regeneron is a leading biotechnology company that invents, develops, and commercializes life-transforming medicines for serious diseases. Founded and led by physician scientists, their unique ability to repeatedly translate science into medicine has led to numerous approved treatments and product candidates in development, most of which were homegrown in their laboratories. They are shaping the next frontier of medicine with data-powered insights from the Regeneron Genetics Center and pioneering genetic medicine platforms, enabling them to identify innovative targets and complementary approaches to potentially treat diseases like obesity and MASH.
LiverRight and the LiverRight Scanning Network. LiverRight is America's first virtual specialty clinic for liver disease, offering adults in all 50 states video appointments and helping GI practices and health systems triage and treat the swelling numbers of patients seeking MASLD and MASH testing. LiverRight offers same-week video visits and accepts insurance. For more information, contact LiverRight. That's liver then R-I-G-H-T as if one word, at www.liverright.com.
Tawazun Health, your partner in global liver health innovation. At Tawazun Health, we specialize in providing small or large-scale access to FibroScan examinations for liver health-focused early detection, clinical trials, independent research, and collaborative projects with clinicians and FibroScan providers, now in over 30 countries around the globe. As industry-leading experts, we design and deliver high-quality FibroScan services because we know that accurate, high-quality, reliable data drives better outcomes. To learn about Tawazun Health or our sister lifestyle app, mylife365.me, click the Tawazun Health link on the SurfingMASH homepage. This week, our roundtable on highlights from the global think tank on steatotic liver disease includes Roger, Jörn, Louise, and behavioral scientist and key opinion leader, Dr. Christina Curtis from the Applied Behavior Change Consultancy in the UK.
This week, our first segment is the second part of the Global Think Tank on SLD Roundtable with Dr. Christina Curtis joining the co-hosts. This discussion focuses on the elements of successful behavior change and the importance of real-time actionable feedback. We discuss the interplay of diagnostic test feedback, real-time personal exchanges, and AI-based algorithms into what Christina terms a hybrid therapy.
The Liver Screen Study, which is a very ambitious project, 30,000 people across Europe, general population, so not only patients with disease, coming up with a relevant subgroup with elevated stiffness, then have to come back, are informed about their decision. I think there's a certain variability of the test, but also some of the behavioral changes, knowing about the results, empowering the patient to think about liver disease in the first place. A lot of them never heard about liver disease, right? They sign up and say, well, I want to think back to Amsterdam, where people were lining up for a number of hours, and I forgot, around the block to know about their liver condition using that NIT. I think this is such a powerful message. And while there's a certain variability to the test, clearly knowing enables you or empowers you to change things.
It's funny, that queue, we scanned, I don't know whether you heard about it, Christina, they put out an advert in Holland on the national news in the morning about how important the liver was, and the liver conference was in town. People queued for 7.5 hours, fasted, to have a FibroScan. We'd have got about 7 people if they'd have queued for an ELF or a FIB4, if at all. But the stories that came out, so I dipped out the conference, we added more machines. I did 5 hours worth of scanning, and we just knocked off over 1,000 scans in 5 days. Not me personally, but the team there did a really great work. But Lauren Sanderin, who invented FibroScan, to be fair, was blown away by the reaction. And I said, Lauren, this is what I see FibroScan as. It is something that motivates and engages, and not just a toy that gives you a very sophisticated calculator that gives you 2 results. It is more than just the physical diagnostic. It is the power to engage populations and we had sommeliers who knew their liver was important to them, who wanted to look after and get their liver health. We had illegal prescriptions of drugs coming in from the UK for weight loss, and people wanted to know their livers. So there was all sorts of really fascinating stories, which you don't get if you sit in a conference lecture. So I couldn't miss that opportunity to really speak to people about what really motivates and powers them to get a liver scan. But to the man, every single one could tell me their weight in kilos and their height in centimetres. In the UK, it's all stones and it's all foot and inches. You can tell we were Brexit for a reason.
But no, that sounds amazing. And I think you're right. It's really important to have that initial hook. And it sounds like that scan was the engagement. If it just been on the news with information of how will you look after your liver, but no, come along and actually do the scan, you wouldn't have had such, I think, of an impact there. But then once you get people engaged, which is great, and that's the hardest bit sometimes, but then how do you actually support them to start making changes to support their liver health? And that's when obviously the kind of more systematic kind of behaviour change approach comes into that as well. And I think we're talking about micro behaviours, which might be getting a scan and things that you do in an app, like tracking and things. And then the macro behaviours are your eating behaviours, your physical activity, your alcohol consumption. So it's thinking about what are as Roger says, the pain points in both of those kind of behaviours. And that's where behavioural science comes in.
So, Christina, let me step you back a sec. FibroScan is a tool that one can use to do that, to achieve that kind of initial engagement. All 3 of you. How broadly can we think about the initial tool, right? It probably isn't a blood test, I'm thinking, or maybe it is. You tell me. What does the initial test that engages the patient, once we get them hooked to come test, what about that test makes it a behavioral tool as compared to simply a data point? What are the elements that do that? If you went to the hospital, if you wound up doing an MRE, would that qualify? If you did a blood test, is there a way that a blood test could qualify? What are the different initial points of engagement where the data that we gave people back about themselves would constitute a behavioral intervention merely than a number?
Yeah, sure. So we can, depending on how they're done, we refer to them as biofeedback as well. And alone, we find that although they can be good at, maybe as we talk about, engaging them in the first place of like, oh, okay, so my liver's in this state, I want to do something to change it. Or then that's where you need to combine it with other kind of behavioral regulation strategies to support whatever you want to change. So that might be, okay, we need to set some goals on a specific, we're going to, look at our dietary behavior. We're going to have a social support element in that as well, which is really, really important. But you have to have the whole kind of goal setting loop in terms of feedback on how you're progressing. So that's kind of just one technique in terms of biofeedback among a whole kind of infrastructure of different behavior change strategies we would use to keep them motivated, to keep them kind of tracking their behavior and to see what their outcome is in terms of their liver scans. Like what impact is me eating a healthier diet or reducing my drinking, physical activity having on my actual liver scans is really important. Because what we often find, if someone, for example, has a heart attack, they might be really committed to actually changing their diet and it's been a health scare, but within sort of months later, they can go back into their normal habits. It's very difficult to change habits. So that's where you need to have the behavior change structure, the kind of what we call environmental cues to change those existing habits. And you really have to restructure your environment. So, but everyone's different. So we use a behavior change model called the COM-B model, which proposes that for any behavior to occur, we have to have sufficient capability. So this is our knowledge, our understanding. This is our general awareness, as well as our attention and our memory and decision-making skills. We also need to have sufficient motivation, which is both reflective, such as our identity, our beliefs about can you change your behavior? Will it benefit you really if you change your behavior? And does it align with your identity as a person that you want to care for your health, for example? And then automatic motivation, which is our emotions, our habits, our impulses and drives. And the third one that needs to be in place is opportunity. And this is divided into social opportunities. So do we have the people in our environment that encourage us to change our our behaviour or hinder? And then the physical opportunity. Do we have the physical resources? So this is the time, the location, the finances that supports behaviour as well. So with every person, it's different. For one person, it might be, okay, I don't have a supportive environment. I've got the motivation. I want to change my behaviour. I understand why it's important. I know how to do it. But the people around me are still eating a really unhealthy diet, or they're drinking lots of alcohol. I find it really difficult to change. And environment, unfortunately, is the biggest impact on our behaviours and the hardest to change. And I have worked in eating behaviours for over a decade. And yes, it's frustrating. You know, we do lots of interventions to help families, but as long as the food industry continues and the environment is such an obesogenic environment, it's very difficult. But either way, we're always trying to look at where is the deficit in that COMBI model, because all three of these conditions need to be in place for change to occur.
And that's interesting because you see it a lot in alcohol, where somebody's not able to get their alcohol themselves. So a partner can be a saboteur. And it's something that we don't really put a lot of time and thinking into in liver disease when we get patients into hospital. But when you make the patient better, or you get them on a road to recovery, you shift the entire family dynamic. And that is really uncomfortable for the person who stays or has been the control and the carer. And the minute you shift their dynamic, they will do something potentially that sabotages the recovery of our patient. So it is not the patient sometimes that has a problem. So when we talk about obesity, when we talk about eating, when we talk about alcohol, it's not just the person that we're dealing with. And SLD is a family condition. It affects the entire family. It affects 1 in 3 of the household around them. And you just need one person, even unconsciously sabotaging that, to really throw it out. So by bringing all of these stakeholders into this room, we can actually look at being more comprehensive in the plans that we put in. And yes, obesogenic society works, but unless we actually upskill our allied health in the way to look at steatotic liver, whether it's in endocrinology, cardiology, I think doctors can't just prescribe our way out of this. And all of the education at the moment is going in at that level. And I understand that because we're getting drugs available. But it's people like ourselves in allied health that spend the face-to-face time trying to work out how do we do this and change somebody's behaviour whilst being aware that there's somebody in the background who might actually be a saboteur. I saw a couple recently this week, both referred for high-risk liver disease. One's eating a bathtub of sugar a year and the other one's eating salad. So where is the collusion and the collaboration within that? Both had fatty liver. However, so you've got to work with the two of them together. So it's a really interesting concept that Christina raises there, but it's something that we as allied health in hepatology need to be more aware of when we say we can't see you for a year, or we can't scan you for 3 years, or we can't do this. We need to change what we're doing if we really are going to support patients coming in this pathway.
Exactly. And that's where digital health can support, you know, because the mobile health app I worked on over 10 years ago, it was a family weight management app. So although it was mainly mums that were involved in the research as the main caregivers, it was also involving grandparents, and it was involving partners as well in a kind of messaging system. So it was all about working together on this. And it is I couldn't agree more. It's a family issue. It isn't just that individual. You know, human behaviours is a complex interplay between habit, automatic responses to our immediate and wider environments. And it's located in, as we've said, complex social environments and cultures. And we can't ignore that. And that's why, unfortunately, interventions fail so often, because they don't address that part. They're just treating the individual and then ignoring the context of that individual and the lives that they have.
So just expanding that group of comments, the one group of participants we had at the SLD think tank was, of course, politicians. I think this is the layer we've been having most difficulties to be engaging with, because really enabling some of the behavior changes, allowing some of the changes on the food industry will require politicians to change some of the laws and the regulations we have. And I think that's why the SLD think tank, and coming back to the general theme, you know, how did the SLD think tank evolve, Roger? I think we actually have politicians and healthcare politicians in the hall and in the discussions this year. And I think this will really help us to move this to the next level and have them realize how bad some of the actions that people choose for themselves are and how to support them in overcoming them.
I couldn't agree more, Jörn. And just, engaging politicians and actually having interventions at the policy level is so important. important. And if you look at smoking as an example, over the last few decades, there was lots of different intervention types, from those kind of one-to-one smoking cessation programs, cigarette packaging with, awful lungs, didn't do anything. It wasn't until the government came in and banned it in public places that we saw a huge shift in actually how smoking was actually viewed by people as actually it's not a very cool, sexy thing to be standing out in the rain, huddling together, having a cigarette. So it really changed the kind of culture of smoking, and we saw a huge reduction for that. And when we think of eating and the food, we haven't gone further enough, and that's how far we need to go. We really need to have it at the policy level and start really, limiting highly processed foods and things like that are coming onto the market and people are thinking are healthy and eating in large volumes of.
Well, you mean all granolas aren't good for me?
No, sadly not.
My other thought, though, Christina, listening to you, is that I'd always thought that one of the reasons that stopping smoking in public places was so effective was because all of a sudden it turned smoking in public places into a pain point for non-smokers, which is it became so much pleasant to be in a place where there was no cigarette smoke that I and many of the people I knew who were non-smokers became a lot more vigilant about letting people know they shouldn't be smoking where they are, right? Because I now felt it. What would be an analog to that for food? Is there an analog where those who don't have fatty liver or don't have diabetes feel the pain of sugar, of excess sugar, in such a way that they stand up and say, you don't want to do that?
I mean, we've tried to tax it the same way we've taxed cigarettes, and it hasn't led to a huge reduction. In fact, the obesity epidemic is getting worse, and particularly in children, and we're seeing more children than ever with type 2 diabetes because of this. I think we need to go further.
On behalf of the surfers, our guests, and our sponsors, Regeneron Pharmaceuticals, Liver Right, and Tawazun Health, thanks for joining us this week.
Please join us again next week when we continue our roundtables on the Steatotic Liver Disease think tank and advances in drug development, and are joined by an outstanding SLD newsmaker.
And until next week, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.